Hello everyone, my name's Lottie. I'm the Communications Officer at the Pituitary Foundation. So I do all of our online events and look after our social media. All the newsletters and emails you get come from me as well. So I'll also just talk a little bit about the Pituitary Foundation, because I'm aware for some of you it might be the first time that you've ever joined a Pituitary Foundation event or engaged with us. So we are a patient support organisation for people that have pituitary conditions. So I'm sure there's a huge range of pituitary conditions or people with different pituitary conditions on the call today. But yeah, it's things like acromegaly, Cushing's, adrenal insufficiency, and we've got a huge range of support services available. So we've got a helpline that's operated by endocrine nurses. So if you've got a sort of medical question, you can ask that. We have support groups, we have online events such as these. We've got lots of information on our website, and also information that's available in print format if that's what you prefer. And we also recently launched our psychological support service. So if you're struggling sort of with your mental health, with your pituitary condition, then that's a really great service for you to get a hold of. And this year we're also celebrating our 30th birthday, which is very exciting. So we've got 30 years of celebrating people with pituitary conditions. So yeah, we've got lots of things going on throughout the year. But so yeah, do check out our website if you want to find out any more about those. I'm going to run through a few housekeeping things just before we get started with the event. So I can see a few of you have got your cameras on. There's no pressure to have your cameras on, but it is really lovely to see your faces. So if you do feel comfortable, please do pop them on. We do ask that unless you're talking, that you do stay on mute. It just helps the sound quality. You can use the closed captions facility by clicking on the CC button that should be at the bottom of your screen. And it's okay to leave the session early if you would like to, and you don't need to sort of say anything. And we are currently recording this session, and we will be popping it up on YouTube hopefully in like a few days' time. So if you want to watch anything back or share it with others, do have a look at that. If you've got any questions, feel free to use the chat. There will be an opportunity for questions at the end. So yeah, we'll kind of have that on the chat initially. And any answers to the questions can't be used as specific advice, and you must still speak to your own doctor. And of course, as we know you all will, please be respectful that people are sharing their personal experiences. So now we've got all of that out of the way, I will introduce our wonderful speakers. So we're very lucky today to be joined by not one but two speakers, which is very nice. So first of all, we've got Dr. Channa Jayasana. He is a consultant reproductive endocrinology and andrology, and works at Hammersmith Hospital and St Mary's Hospital, as well as being an academic at Imperial College London. We've also got Dr. Rhianna Davies, who is a senior registrar in gynecology, and she's also accredited by the British Menopause Society as a menopause specialist. So this evening we're going to be talking all about kind of menopause and pituitary conditions and kind of what that means for you. And yeah, so we'll have, I think it's like a 15-20 minute talk, and then lots of time for questions. So Channa and Rhianna, I will hand over to you.
Okay, so hopefully everyone can hear me. Thank you very much, Lottie, and to the Pituitary Foundation for the very kind invitation for Rhianna and I, who work together at Imperial College, to talk about problems of low estrogen, which are associated with pituitary disorders in women. So I lead a large service where we provide advice to women across much of the UK, and we tend to we have a lot of patients who have pituitary problems, and one of the key concerns and things is, if we look on this slide, the pituitary obviously controls many of the endocrine organs, such as the thyroid and the adrenals, etc. But critical to this, the pituitary gland makes LH, so luteinizing hormone, and FSH, follicle stimulating hormone. And these are under the regulation of another bit of the brain called the hypothalamus. And whether you've had surgery or another condition causing these hormones to be deficient, to be low, what that will do is reduce the stimulation of the ovaries that you would normally have. And so normally what will happen is during puberty, you get sort of these spikes, these pulses every hour of LH and FSH, which signal the ovaries to do a couple of things. One of them is to make estrogen, which circulates around the body and does a variety of things, including mineralizing the bones, so thickening them. It's important for sexual function, for libido, for skin softening, joint development. It can also have profound effects on mood as well and well-being. And also, obviously, egg growth and development needed for fertility. Okay, so on to the next slide, if we can. Perfect. So I think this is probably arguably the most important thing that I want to kind of demystify and get across, because we were asked to do something related to menopause. And I think, I don't know about you, but certainly amongst some doctors, non-specialists particularly, there's a bit of confusion over whether all women who have pituitary problems have menopause because their periods stop. And that, I would argue, isn't strictly speaking the case, because menopause is an age-related condition that all women go through when the ovaries run their natural life course, and sometime between the ages of 40 and 60 stop working. And that's an inevitable part of the life course of women. And that is an ovarian problem. And that is irreversible. Whereas any problem in the pituitary, actually, so imagine the ovaries are like the light bulb. Well, actually there is, as you'll see here, brilliant sort of iPhone-esque terminology here. So if we look, so with age-related, so in other words, menopause on the left, we can see that the pituitary is working, but actually the ovaries are switched off. Whereas on the right, we have what actually happens when you have a pituitary problem, which is there's nothing wrong with the ovaries, but they're not being stimulated because you're not making LH and FSH. And that's what causes the period loss. So it's not menopause at all. It's what we call hypogonadism, which leads to amenorrhea, so an absence of periods. And we can talk about that certainly. And the thing that I'll touch upon is that what's on the right is potentially reversible. So there are some pituitary problems that with treatment, depending on what you have, can actually go the other way if whatever is going on, such as a tumor, gets treated, for example, and some congenital, so some things that you're born with, if they get better, then actually the signal can return, and you do find in some instances LH and FSH recovering and periods recovering. Even if they don't recover, provided you are of an age, before, say, the age of 40, then there is scope to actually have fertility treatments to stimulate the ovaries, which aren't being stimulated by your pituitary. So why does this all matter? So having hypogonadism, so in other words, low estrogen, low ovarian function, and period loss can affect a variety of different things. So first of all, estrogen is a critical component of what makes your bones mineralize, so sort of absorb calcium and phosphorus. And so particularly before the age of, say, 45, women are meant to be using estrogen to combine stuff that they've eaten, so using vitamin D as well, but calcium from food to basically strengthen your bones. And over time, having an absence or a low level of estrogen can lead to the bones thinning, and that can lead to things like osteopenia, so thinning of the bones, or if it's more severe, osteoporosis. But that can be reversed by having what we call HRT, so hormone replacement therapy. And these are what we call bioidentical, so synthetic, so man or human-made versions of estrogen, which are usually given with progesterone to allow withdrawal bleeds. Other factors, so having low estrogen can affect concentration and give people symptoms like brain fog. And also having a low estrogen has been associated with, in a population, increasing risks of heart disease. So estrogen is what we call cardioprotective. That's one of the reasons why women have lower risks of heart disease than men, because your estrogen gives more favorable effects on blood pressure and cholesterol, etc. And if you have low estrogen, then you lose that that benefit. But again, hormone replacement therapy can restore that. And finally, fertility. So HRT will not restore your fertility, but as I said, if it doesn't actually spontaneously resolve on its own whatever has caused the pituitary problem, if you have something that's irreversible, provided you are the right age, if you are, say, below the age of 40, and personal circumstances will adjust that age for various things, and we can talk about that later, then going to a specialist such as Rhianna in a fertility clinic, you can have special hormones to replace the pituitary hormones that are missing to kickstart the ovaries working temporarily for fertility. And that's a specialist but established treatment, which we call ovulation induction. Okay. So the next issue is, I guess, what can we do? So number one, let's, as I said, there are sometimes means of resolving the underlying problem. So one common pituitary problem is having too much prolactin, the milk hormone. And prolactin can be treated with medications. And if you have a prolactinoma, so in other words, a small benign growth that causes prolactin, that's classically causes period loss and can interfere with periods, etc. So by giving medications, you can cause the pituitary tumor to regress and sometimes even disappear, or surgery can sometimes actually do this as well, and you can resolve the underlying problem. Another thing is replacing hormones. So in other words, HRT, and I think Rhianna's going to talk in a little bit more depth about some of the practicalities of that. Perfect. And yeah, so Rhianna, what, if you're happy to, would you like to sort of go through a little bit about the details of sort of self-care and other things?
Yes, absolutely. So this first slide shows, and this is just putting HRT aside for a moment, not because it ought not to be used, but just because there are adjuncts and also things that you can take alongside. And this slide shows things that people who go through the menopause as an age-related menopause may or may not opt to have HRT. And so these are many factors that women who have low estrogen for whatever reason might be able to do to improve things to a degree alongside their HRT. So here is lifestyle changes. Caffeine, nicotine, spicy foods, alcohol, all worsen hot flushes and night sweats. Alcohol is good to get you off to sleep, but actually your sleep quality is impaired, and caffeine obviously not good for sleep. And so altering of lifestyle habits can help symptoms to a degree. Also, one of the symptoms of low estrogen are urinary symptoms, so more likely to be getting up at night to wee, needing to dash to the loo, feeling like you've going to wee loads and there's actually not very much, feeling like you mayn't get there in time. And alcohol, nicotine, and caffeine all increase those urinary symptoms. Exercise, mainstay of lots of treatments for lots of problems, but regular weight-bearing exercise, really good for bones, really good for sleep, really good for mood. all of things that can be disturbed with low estrogen. The Sleepio app, it's an NHS app available on iPhones that helps you do sleep hygiene and track your sleep. Acupuncture, evidence is not quite there, but some people find it hugely beneficial for mood changes and sleep disturbance during periods of time when their estrogen is low. In the middle here, these are really medications for people who have symptoms that need controlling, but who for whatever reason can't have HRT. Perhaps less applicable here, but they can be taken alongside HRT if symptoms aren't completely sorted. And these tend to be drugs that are used for other things in medicine that completely perchance happen to have been found to help. So for example, venlafaxine there, it is an antidepressant, but it also reduces hot flashes. And then on the bottom right are over-the-counter, so Holland & Barrett style supplements that can help. Female is made from pollen, helps quality of life, improves mood, reduces hot flashes. But the reason I put this in is one's got to take a little bit of care, because if you're on HRT and you're also looking to take supplements, be very careful not to necessarily take ones that contain phytoestrogens, because then actually it's not quite clear how much is or isn't getting into you if you're having it from various sources. So then on to HRT. There are absolutely loads of ways to take HRT, and it depends upon personal preference, whether it is likely that you may intermittently have return of your pituitary and ovary functioning, such that sometimes you may have periods, or might they return, or is it known that they won't return? And actually, do you favour or not favour having regular bleeds? And all of the symptoms of the menopause are due, or of low estrogen related to pituitary conditions, are due to low estrogen. HRT in someone who still has their uterus is two drugs, estrogen and progesterone. Progesterone does nothing for symptoms. It's just there to protect you from estrogen. And estrogen is what you need for symptoms. And symptoms of the menopause include brain fog, inability to concentrate, poor sleep, hot flashes, night sweats, anxiety, moods up and down, loss of confidence, joint pain, vaginal symptoms, so soreness, dryness, loss of libido. And so replacing the estrogen is important, and the progesterone's role is to protect you from estrogen. So in a normal menstrual cycle, estrogen builds the lining of the womb, and progesterone is a halt on that. And so if you were to take estrogen just for symptoms, the lining of the womb would grow and grow, and ultimately there is a risk of uncontrolled growth and precancerous cells. And so it's important that everybody who takes estrogen, who has a uterus, also takes progesterone. And as long as that is done, then the progesterone does not cause that harm. And so how you take progesterone is then up to what suits your lifestyle. So you can take a pill that does it all. It's got the estrogen, the progesterone, and it does it for you, like in the contraceptive pill. Or you can separate them. You can have a patch that does it for you that's got both in. Estrogen through the skin is considered safer. So estrogen taken as a tablet, any estrogen that goes through is swallowed, goes through your liver and is converted to a clottier form. And therefore the risk of blood clots in the legs and the lungs are higher if you take estrogen as a tablet, same as the contraceptive pill, and totally fine if there's no particular other reason that puts you at higher risk of blood clots. If you were to have higher risk of blood clots or wanted to just take the super safe, the most safe version, then you could elect to have it through your skin. And that doesn't increase the risk of blood clots. So as a gel, so it's a pump, so one dose, you push the pump all the way down and you have one dose, or a patch. And this is done daily. This, depending on the brand, is done 2 to 3 times a week. And that is your estrogen sorted. You can also have it as a spray. If you're someone who does regular travel, you can have ones that come in small sachets that you can take in hand luggage. And then the progesterone alongside it. So the options for the progesterone are as a pill. And this one here is body identical. So made in a lab, like all other forms of medical hormones, but it is identical biochemically to the form we make in our body, so a gentler form. And this can be taken as a tablet, either daily, if you are not someone who's at risk of having breakthrough bleeding, or we can tailor it so we can give you it for half of the month to ensure you have a monthly bleed, or we can tweak a little bit further if you're having irregular spotting. One of the advantages of this one is that if you are someone who, when you had periods, had bad PMS, and that's due to progesterone, and therefore taking this gives you it back. This also comes in a vaginal form, which avoids any of the mood side effects. So you're less likely to get premenstrual tension type symptoms. This is a Mirena coil. It's a really good choice because once it's in. You've not got to remember to take anything. And if you're someone who, if your symptoms may resolve, your pituitary disorder might get better, unpredictably, this is also contraception. And if you're someone who requires contraception, this is quite handy. The advantage of this one, the Utrogestan, is it makes you sleepy, just as a complete byproduct, just as a side effect. Really good if you've got sleep disturbance due to low estrogen. So bottom line is loads of options, and the doses are very easily tweakable until you feel back to normal. But are there risks? Well, lots of the information that we have about the use of hormone replacement therapy is not in necessarily the younger age group. So not that there's necessarily a huge amount either, but the studies that have been done are more likely to be done in women who have gone through an age-related menopause. So for example, over the age of 50. So these are really the three biggies. So blood clots, as I say, if you take estrogen as a tablet, increased risk of blood clots in your legs and your lungs. We can get around this by giving it to you through the skin. If you're not someone who has any other risk factors for blood clots, so blood clotting disorder, you've previously had a blood clot, someone in your family has, if you're of a higher weight, if you don't have any of those risk factors, there's no reason you can't have it as a tablet. If you do, there's no reason you can't have it because you can have it through the skin. Bleeding, so estrogen builds the lining of the womb, progesterone is a halt on it, and so if we don't get the balance quite right and you have more estrogen relatively to progesterone, you might have random bleeding. Is not very clearly known, and it's different for different women, what dose of progesterone is needed to protect you against what dose of estrogen and what dose of progesterone will control bleeding. And so sometimes there's a little bit of tweaking needed. Some people will need more progesterone to control their bleeding. But from a risk point of view, as long as you take progesterone alongside your estrogen, the risk of uncontrolled growth and the precancerous cells developing and being left and ultimately becoming cancer is therefore controllable. So as long as we give it to you properly, that is not a risk. The breast cancer risk, tricky, because the information that we have about it is in an age group that is older than many of you. So in an age group of, for example, 50 to 50, this is taken from 50 to 59-year-olds, and there is a small increased risk in breast cancer. So you can see the blue is the number of women who are destined for breast cancer, who are not taking HRT for other reasons. And this is 4 additional women. If all 1,000 women, so this is 1,000 women, 23 will have breast cancer for other reasons. If all 1,000 take HRT, 4 extra women who otherwise were not going to have breast cancer will get breast cancer directly due to their HRT. 4 in 1,000. Put it into perspective for other things that increase your risk of breast cancer. However, this information is from studies from women over the age of 50. And we're not aiming to give you hormones for longer than you otherwise would have them. We're aiming to give them until the age of the natural menopause, which is 53 on average. And so all we're doing is bringing you back up to the level that, had it not been for your pituitary condition, you would have anyway. So it can be assumed, though not necessarily, it hasn't been studied in depth, that all we're doing is replacing what you otherwise would have. And those risks, that increased risk of breast cancer, oughtn't to apply. This slide just shows that there are some HRT prescribed. In some patients, HRT prescribing is tricky. So women with migraine, migraine can be worsened. It can be worsened by fluctuating hormone levels, but it can also be worsened by estrogen. And so having migraine does not mean you can't have HRT, but it would be advised to avoid especially if it's migraine with aura, to avoid the tablet form and to have your HRT through the estrogen component through the skin. High blood pressure, absolutely not a reason not to have HRT. And in fact, different forms of the progesterone part of HRT have actually some beneficial benefits on, say, your lipid levels and your blood pressure. And it's really important to know that estrogen protects you. So if you take men and women before the natural age of the menopause at 53, strokes and heart attacks are more likely to be men. And then after the age of natural menopause, women catch up and it's 50-50 because they've lost their estrogen protection. And so by ensuring decent estrogen levels, you can keep yourself in that protected category. This is showing blood clots. And again, as long as you have your estrogen through the skin, that doesn't increase your risk. And this is just to show that you may have some unscheduled bleeding, but that can easily be controlled by either increasing your progesterone or thinking about a coil. Something I haven't got slides on, but I think is probably important to talk about, are vaginal symptoms, and probably ones that people would feel less comfy going to their doctor about. We've estrogen receptors all around our body, but lots in the vagina, around the neck of the bladder, vulva. And so in the absence of estrogen, the bladder becomes generally irritable. So getting up at night to wee, feeling like you need to rush to the loo, getting UTIs more often than you otherwise would have done. So lots around the bladder neck becomes just generally fragile and irritable. Same for the tissue of the vagina, becomes thinner, less elastic, irritable and sore. And so sex is miserable. It can sometimes actually just be uncomfy sitting, and lubrication reduces because of the balance of the various bugs that naturally live in the vagina, which are altered during periods of low estrogen, more likely to get things like thrush. And so lots and lots of women will have symptoms of urinary or genital symptoms. And those, again, they can be sorted by having decent levels of estrogen. Having estrogen that you take as a tablet or as a patch doesn't fix them quickly. So when you take HRT, so hormone replacement proper, it doesn't quickly solve those symptoms, but it will in due course. But while you wait for your systemic HRT to catch up, you can have estrogen just where you need it. So a cream or a pessary, so a tablet that you insert as high as you can, let it dissolve, because the cervix at the very top of the vagina also has lots of these estrogen receptors and also becomes fragile. And that's often why sex would be sore, but also often people have a little bit of bleeding because that tissue has just become so fragile. So while you wait for your HRT to catch up, you can have estrogen as a cream, as a tablet, and that will sort lots of urinary symptoms, going to the loo all the time, getting up at night to wee, and also make everything generally comfier. When you have low estrogen, generally speaking, you'd need to use a good lube during sex. Yes, as in the word yes, or Silk with a Y, are good and credible brands. Again, while you wait for your HRT to catch up and sort the problem itself.